Well, I want to welcome you all to our inaugural session of Frontiers in Oncology. This is a new seminar series that I have just initiated, and it's intended to be a bi-monthly seminar series to bring in some of the most impactful leaders in clinical oncology and translational oncology to campus. And to have a very broad audience to our cancer community at Stanford. Of course, now it's virtual, but our hopes and dreams are to make this a real in-person meeting at some points in the future. And I'm showing you our inaugural speaker here, Alyc Adams, whom I will introduce in a moment. And just also to indicate that we have another speaker, Jeff Shapiro, who will be scheduled shortly in August. And then we are going to co-host the 7th annual Carl Bluma Memorial Lecture, and Dr. Catherine Tierney will be the featured speaker at that important seminar. And that will be on August 11th in the same time slot, Tuesday, August 11th at 8 a.m. So now, without further ado, I would like to introduce our featured speaker for today and our inaugural speaker for Frontiers in Oncology, and it's Dr. Alyc Adams. Dr. Adams received her PhD from Harvard, and she was an assistant professor at Harvard for several years before she was lured to the West Coast to Kaiser in their division of research. She rose in the ranks there, and she now is the Associate Director of Healthcare Delivery and Policy. Dr. Adams is a renowned expert in health services and health policy science. She works to understand the impact of changes in health policy, how that affects access, and the use of clinically effective healthcare services among vulnerable populations. She also works to understand and address the disparities in treatment outcomes among patients with chronic medical conditions, including cancer. And we're thrilled to have her here with us today. So welcome, Dr. Adams, and I will let you begin. We're going to have questions and answers at the end of Dr. Adams' talk. So welcome, Dr. Adams.
Thanks so much, Steve, and please let me know if the audio is clear. Thank you so much for that very generous introduction. Today I'm going to be talking about advances in health equity research and specifically focusing on the critical role of community engagement. And specifically, as Steve mentioned, my name is Alyc Adams. For the last 20 years, really, I've been really focused on addressing and understanding suboptimal treatment outcomes for individuals with multiple chronic conditions, and particularly those who are among vulnerable populations or disparities populations, so racial and ethnic minorities and lower income people. And that work has really sort of been motivated by my own experience. My family grew up in Arkansas and Oklahoma originally, and so really sort of watching my older relatives succumb to things like breast cancer and diabetes and hypertension, and watching their increasing disability over time, including the loss of sight, the loss of hearing, the loss of mobility, the loss of limbs, and hearing them say things like, well, this is inevitable. It's just what happens when you get diabetes. It's just what happens when you get hypertension or cancer. And that really sort of resonated with me and struck me as being not only wrong, but something that we could do something about. And so that really inspired me to really devote my entire career to the idea of trying to improve healthcare outcomes for disparities populations. Over the last 20 years, like I said, I've worked a lot in policy as well as health services research within integrated systems like Kaiser Permanente. And more recently, I've increasingly gotten into sort of more leadership roles, trying to understand how can we build infrastructures that really support the type of research that has the potential to impact these populations. And that includes working with the Cancer Research Network, with Larry Cushy, and again, the associate director role that Steve just mentioned, as well as my role now as multiple principal investigator of the Aging Initiative, which is an NIA-funded initiative, which has a very specific focus on aligning patient and caregiver priorities with those of scientists. And through all of that work, I have to say that I'm increasingly hopeful about the future of health equity in the United States and beyond, and as well our potential as scientists to have an impact on that work. And so I want to talk today and I've been divide this talk into two parts. The first part is really about key findings from the research that we've done over the last 20 years in health equity, and really specifically related to chronic disease care and outcomes. The second part is really more about the stakeholder engagement, and why I think it's a catalyst to addressing some gaps in research impact. So first of all, and many of you have seen this slide or versions of it around healthcare disparities. And it's just really to emphasize that healthcare disparities, which we define as differences that are both preventable and unnecessary, are both multifactorial and interacting. They vary over the life course, they vary over time, they vary across populations and geographic locations. And the specific influence of these different factors differs depending on the type of chronic disease you have and the sort of your progression along that chronic disease in terms of where you're at in terms of treatment as well as control. And so all of these factors really come into play in terms of how we think about healthcare disparities and what we can do about them. So if there's nothing else I want you to take away from the work that we've done, I think it's really sort of two key lessons. The first is that equal access is necessary but not sufficient to address these persistent disparities. And the second is that when it comes to quality improvement, a rising tide does not necessarily lift all boats. So I'm going to start with this first notion that equal access is necessary but not sufficient. Many of you have seen this or some version thereof, but it's this idea that if we treat everyone the same, we're not going to get the outcomes that we need because everyone's not coming from the same place. Right? Everyone's doesn't have the same starting place. And that's of course illustrated by this particular graphic, but many other graphics as well. But the idea that it's not enough to say we're going to treat everyone the same. We need to understand the needs of individuals and the needs of communities, and then adjust care and adjust practices and policy to address those needs. So one specific work that I want to talk about that really sort of speaks to this, it's not sort of the only work that we've done that really sort of reflects this, many have, but I think it's a nice illustration of what I mean by equity equity and access is not enough. And that specifically has to do with Medicare Part D. So for those of you who are familiar with drug coverage and the evolution of drug coverage in Medicare, initially there was no prescription drug coverage in Medicare. So essentially you got coverage for hospital care and eventually you got coverage from primary care, but you actually didn't get coverage for medications. And so when I was graduating, there was this common sort of focus on the escalating costs to the elderly of medications and the fact that many of them couldn't pay for them. In particular, this is disproportionately hit minority individuals, low-income individuals, and those with multiple chronic conditions. And so at that time, Congress was interested in knowing, should we increase access to these populations? And so over time, they implemented Medicare Part D, and our evaluation really sort of focused on what was the impact of Medicare Part D on racial differences and known disparities in the use of clinically effective therapies in two areas, both with cancer and diabetes. This was my first R1, this was NIA funded. We also had some funding from AHRQ to do this work. Our work really focused on the fact that African-American Black Medicaid or Medicare enrollees were actually more likely to be living in states with very restrictive drug caps under Medicaid. Now, these are individuals, I should mention, that are dually eligible for both Medicaid and Medicare. So as a result, just happening to live in a state with very restrictive drug caps, which meant that beyond a certain point, say 5 or 6 prescriptions per month, the government stopped paying, and the individuals are then responsible for the full cost of medications. It's a very sort of restrictive policy, and one that we've shown previously has a big impact, a big negative impact on the use of clinically effective services. So when Part D came around, drug caps were not allowed under Part D. And we moved, or the country moved dual eligibles from Medicaid drug coverage to Medicare drug coverage. So we took advantage of this natural experiment. We took advantage of the fact that patients either lived in states with very restricted drug caps or no drug caps. And then we looked at those individuals by race and race, specifically race and white and Black race, to then understand the impact of the lifting of the drug cap as we transitioned these individuals to Medicare Part D. They all transitioned at the same time. And what they transitioned into varied depending on a sort of an automated or randomized process. But overall, we knew that people were moving, a lot of people, and particularly Blacks, were moving from restricted to less restricted drug coverage. So we wanted to see what was the impact of all of that for people with cancer and diabetes who have dual coverage. So we use primarily interrupted time series with comparison series designs. So that's really sort of leveraging the fact that this is a natural experiment that's happening at a point in time where we have a lot of information about what was going on in terms of utilization of these medications prior to Medicare Part D. And then we could use that information to then extrapolate about what was likely to happen in the years past Part D if Part D did not happen, right? So that counterfactual, we could get there using prior data. We could then compare that to what we actually saw with respect to Medicare Part D, and then leverage natural differences across states in terms of the restrictiveness of drug caps, using that as a lever to say, if you happen to live in a restrictive state versus not a restrictive state, if you were Black or white, what was the effect of all of that, all of these changes on utilization of clinically essential services. And so we use a nationally representative sample of Black and white adults with fee-for-service dual enrollment between January 2004 and December 2007, which was essentially in the 2 years before and after the implementation of Part D. And we really focused on those states where they did or did not have restrictive drug caps before the implementation of Part D. So all the complexities of that policy, let me just sort of get down to the nitty-gritty. What did we find? Well, we found that when we looked at white-Black disparities, and this line actually represents the difference between whites and Blacks in terms of the proportion using antidepressants who had cancer and concurrent depressive symptoms. We looked at across a number of different categories, but this is a particularly interesting one, where we knew that a disparity existed prior to the policy. What we found is that when individuals moved from restrictive to non-restrictive drug cap, to less restrictive drug coverage, what we found was that the white-Black disparity in antidepressant use among people with cancer and concurrent depression actually reduced. And this was not just in terms of antidepressant use. We also found this when we looked at cancer survivors who were also using, for example, lipid-lowering medications or antihypertensives. We saw this kind of consistent evidence that lifting this restriction on the use of clinically essential medications for these individuals resulted in a reduction in the disparity between whites and Blacks in the use of those clinically effective medications. Now, in contrast, in diabetes, we saw something very different. And this shows you the same drug classes as the antidepressants among diabetes patients who also had concurrent depression. And what we found, which is represented by the dashed line, was actually an increase in the difference between whites and Blacks pre and post Part D when the restrictions and drug coverage were lifted. And specific, this was due to a greater response among whites to the policy than among Blacks. And you do see, again, a response among both subgroups, but whites responded more, and they continued to see some sort of benefit from the removal of drug caps post Part D relative to Blacks, which resulted in that dashed line increasing over time following the implementation of Part D. So why does this happen? This is not new. It's been shown again and again in different policy arenas. This idea that often those who are most likely to benefit and those who might even be focusing on for interventions are sometimes last to actually experience the benefit of those interventions or innovations or expansions in coverage. And this comes from work in Brazil and in numerous other arenas where we've shown that prior to the instigation of an intervention, and this is a lovely graph by Tabucchi et al. That really describes it. If you go out to the second dashed vertical line, what you see is for this first two segments are really sort of the national course of disparities. We see these inequalities in utilization and outcomes, et cetera. And then when we actually intervene to address them, we remove a barrier, for example, as we did with drug coverage, what we often see is not a narrowing of the disparity, but a widening of the disparity. And that disparity often widens further the more intensive the intervention becomes until the fact that the majority population sort of reaches its maximum benefit. It's not until then often that vulnerable populations can sort of start to see some additional benefit from the intervention or some benefit from the intervention. Now this again works across benefit expansion, it works across technology innovations and care delivery innovations. And we tend to see it across conditions, though in our case, we actually did not see this widening in cancer. We actually saw a narrowing of the disparity, but we did see it in diabetes. And this really intrigued me. I wanted to know sort of why is this happening and what do we have to do to address it? So we actually concluded that part of the issue might be what's going on with concurrent interventions. And this somewhat speaks to this difference that we saw between diabetes and cancer. So in the case of cancer, there's a lot of intensive care, a lot of different providers working together for a specific patient's needs. And it's a very intensive sort of period of time in which the patient is very fully engaged in the healthcare system. And we hypothesized that may actually be protected, that high level of engagement between patients and providers in the healthcare system may actually be protective against this sort of inequity hypothesis. In diabetes, it's sort of the opposite case, where diabetes, we don't have this sort of highly intensive period of intervention. You could argue at the beginning of a diabetes diagnosis, you see some of that, but really it doesn't come anywhere near to comparing to what happens in cancer. And so we started thinking about, well, what would you need to do to avoid this paradox? How can we avoid worsening disparities by trying to make things better and more accessible for all of our patients? And so we noted a number of different things that seem to make a difference across the literature and in some of the work that we've done. One is addressing variation in the quality of care across settings. To the extent that underrepresented or vulnerable groups are more likely to get poorer quality care because they're in low resource settings, for those individuals, we might expect to see that they have a harder time taking advantage of these expansions of coverage, for example, because they're in a lower quality setting. So addressing those sort of quality issues in care settings might be part of the answer. Another is in enhancing patient trust and engagement in the healthcare system. The bottom line is it doesn't matter if we make medications free. If some groups are less reluctant or more reluctant to take those medications, either because they don't believe in them, or because they're having trouble communicating with their provider about them, or they have serious concerns about side effects related to those medications, et cetera, no amount of money is going to change some of those things. And so really thinking about what does it take to gain trust and engagement of these patient populations in the healthcare system and in treatment such that we can engage them further. Another issue is overcoming communication gaps. This idea that this not only health literacy that becomes a problem and language that's an issue, but also literacy and understanding of your healthcare benefits. We've seen disparities across all of the knowledge of all of those factors. And so when you have that sort of cumulative risk building up between language barriers and health literacy barriers, as well as barriers in terms of your understanding of coverage, you can imagine how all of those gaps could contribute to this paradox. And lastly, we talk about sort of addressing provider behavior. The reality is that throughout all of the studies that we've done, we found consistently that there are differences, systematic differences in prescribing across race and ethnicity that aren't well explained by differences in need, in clinical need or biology. And often what we see is that providers, generally speaking, are more likely to prescribe lower cost, but also potentially medications with poorer sort of tolerance profiles for minorities than they are for other groups. And so when that happens, the question is, what do we need to do to change provider behavior around those issues? And it may be that providers are being protective of their patients, but at the same time, if they're providing them with medications that have higher levels of side effects, we're less likely to see uptake as well as ongoing engagement of those medications, regardless, again, of the cost of those medications. So that's sort of in a nutshell some of the quality work that we've done around, the work we've done around policy, but we also have done some work around quality improvement. And what we found is that when it comes to quality improvement, a rising tide does not lift all boats. And this really speaks to some of the questions that were being asked about disparities back in 2003. For some of you remember that then IOM had put out a report around disparities. And people were sort of shocked about the level of persistent disparities in our country. And there was a lot of conversation at that time about the rising role of managed care and population management and whether or not that could be a way to address disparities. If we improve overall quality, if we make it harder to see these deviations in prescribing and deviations in communication by creating a system that really sort of supplements the patient-provider relationship and really promotes guideline consistent care, can we sort of rise all boats with the tide, right? We've improved quality improvement for everybody. Will it therefore help us to reduce or maybe even eliminate the gaps? And this was really a hope for managed care and for population management and chronic disease management when I was sort of coming out of my PhD program. And so what we found is a number of different things. We've done a number of studies using observational research and qualitative methods and other methods to really understand the context of decision-making within these healthcare systems and how various policies and practices contribute to the reduction in disparities, or worst case scenario, contribute to the exacerbation of these disparities. And one of the things that we found was in terms of looking at changes in control over time, is that even when we looked at patients who were newly diagnosed with chronic diseases, and again, this happened with diabetes, cancer, hypertension, depression, these disparities that we're bothered by in terms of by race, ethnicity, by income, et cetera, appeared very early on after the initial diagnosis and very early on after the initial treatment of these conditions. And what you're seeing here is some work that we had done back in 2008, looking at diabetes A1C control among Blacks and whites, where we saw for men and for women, there was a gap that existed at the time we identified these individuals having diabetes. And for at least in terms of men, the gap actually widened over time. And again, I'm using diabetes as an example here, but the reality, this also happens for hypertension and cancer and depression and other chronic conditions. We also found that this result was also consistent with what others were finding at Kaiser Permanente. I was at Harvard at the time, but others at Kaiser Permanente and other places were also seeing similar patterns. It didn't really matter where you went in the country, you saw this sort of pattern where certain groups were almost always sort of at a lower sort of rate of control of chronic disease and chronic disease outcomes, regardless of where you were, whether it was managed care in Boston or managed care in California, for example. Another thing that we found was that the use of EHRs to embed sort of population management tools to promote quality improvement as well as evidence-based care were really successful in reducing disparities in processes of care. So this is just an example of LDL cholesterol testing and control. It was some work that we had done with Dr. Tom Sequist out at Harvard Vanguard. And basically it showed that before the implementation of EHR-based population management strategies, we saw a lot of variation in terms of LDL testing. And then after the implementation of these strategies, we definitely saw an increase in testing and quality, guideline consistent quality care. That actually has increased dramatically since then, up into the 80s and 90% in terms of the patients who have guideline concordant care in this case. And then when we looked at things like, for example, control, we saw a different story. One was that control was worse initially than it was for processes of care in terms of who was getting what. And then we also saw after the implementation of these population management strategies that while control did improve, we didn't see the more dramatic improvements in control in outcomes that we saw for process measures as we did for control. In addition to that, the disparities in control by race and ethnicity, this only shows Black and white, but we also have looked at this by other racial and ethnic groups. And what we saw was that the disparity was even greater in control. And so this also spoke to this idea that, you know, just improving quality of care overall probably isn't enough to address some of these persistent disparities in control for patients with multiple chronic conditions and with specific chronic conditions. Finally, this is another example. This one comes from hypertension, but again, we've seen this across a number of different diseases, including cancer and diabetes and mental health. And that's simply that health system engagement seems to be an important mediator of these disparities in control and in self-management, like adherence. And so specifically what this paper did is we looked at early non-persistence and non-adherence to antihypertensive medications across different racial ethnic groups in a population of patients who were newly diagnosed and treated with hypertension. And so what we found was that we found disparities certainly in early non-persistence, which was really, did you ever refill the first prescription? And that was across most of the racial and ethnic minority groups that we looked at. We also saw it by income and other factors. When we got out to non-adherence, so those individuals who had filled that first refill, so they were engaged, they were actually treatment engaged, what we saw was that the disparities that we saw previously were actually attenuated when we accounted for whether or not they were they had copays that were below, for example, $10 relative to 10 to 20 or 20 or greater. We also saw that those who were enrolled in mail order pharmacy programs, which essentially makes it increases ease of access access to these medications, as well as a bit of an incentive, financial incentive to adhere to these medications, that when they were enrolled in those programs, we actually saw a decrease in disparities. And similarly, when patients were prescribed the same types of medications, again, we saw sort of this attenuation of racial and ethnic differences in adherence to treatment. So what does that mean? It means that improving overall care is important, but unlikely to address persistent disparities in chronic disease care. And there are a number of different reasons. And one is that disparities in treatment and control persist even when the overall quality of care improves. And this suggests to me that targeted interventions may be required to sort of move the needle further beyond processes of care into control. Another factor that we uncovered was that quality improvement at the population level was associated with reduced disparities, again, in processes of care, but that the disparities of control persisted. And finally, that disparities populations may be less likely to engage in programs that, when they actually do engage in, are likely to be equally beneficial to them. And so really, it's not that we don't have interventions that could be effective for these patients, but they're not engaging in those interventions. So we need to think differently. And I think this really sort of started to turn how I was thinking about managed care initially as maybe a panacea for some of these issues. And certainly, I think there's been some leaps and bounds and certainly progress in that area, but it really had me thinking about what more can we do? What do we need to think about in order to sort of really move the needle? And so I think I'm not unique in sort of my consternation about these issues. Health disparities research in itself as a field has been sort of stuck a little bit at this phase of detecting and understanding disparities and having more and more trouble trying to address them. And so Amy Kilborn, who was at the VA, did this fantastic sort of picture of the sort of the trajectory of health services research around disparities, if you will, really sort of moving from detecting, understanding to addressing. And some of the work that I've been doing is really, sort of, as you saw, sort of focus on policy and system level interventions that either help us to understand those disparities and or to address them. And I think we've gone a long way towards understanding how these factors, whether it be cost or other health system level factors, influence disparities. Where we sort of run short is really sort of figuring out how do we use and leverage these things to address those disparities. And so the question then is, why are we stuck? Why are we having this trouble? And I think it's a number of different things. One is that we found that the most successful interventions around disparities in chronic disease control really tend to focus on the issues of sort of the multifactorial and complex nature of the disparities themselves, right? So we have those interventions that are most successful are actually incredibly complicated, difficult to be portable across settings, and difficult to maintain over time because they are so complex. Moreover, we have challenges in evaluating them. In addition to that, so even if we're looking at natural experiments, when you have the kitchen sink approach, it's hard to know which component of the kitchen sink is the most relevant and the most important to integrate. And certainly most trials and other types of methodological innovations are helping us to start sort of get around those issues, but these are significant barriers to research in this area. Another area is the lack of integration of community and healthcare system level interventions. And so what I mean by that is really this fact that we have the healthcare system doing its part and the community trying to do its part, but rarely the two meet. And so I've been working in managed care settings as an embedded researcher for the last 20 years. And I will say I've been surprised at the fact that I work within a managed care organization where we're constantly doing interventions to try to address disparities. And those same managed care organizations are giving money away to the communities in order to stimulate disparities reduction activities in the community. But those are rarely aligned, and hardly ever do we come together to talk about what can we learn from each other and how can we think about the cumulative effects of these combined interventions at the health system and community level, as well as even the policy level on disparities. We rarely make those connections. Finally, I think there's a failure here in the research that we've done. It's certainly critical of the research that I've done, but it's certainly of the field, and that's we failed to address, I think, some of these broader contextual issues that contribute to community risk as well as community resilience. We have something in disparities research that we talk about a lot, which is the neighborhood deprivation index. And often that index is associated with some of these disparities in control and adherence, et cetera, that I've been talking to you about. And while that's useful for helping us to understand the specifics about communities that are barriers to adherence and barriers to control, what we have not done, and what we fail to do is to really fully understand what are those factors in communities that are resources that contribute to the resilience of communities and their ability to overcome some of those barriers. That the people who are now doing really innovative work in these areas in a number of different sectors, and I don't mean to imply that that work is not being done, but overall, the vast majority of the work to date has really focused on these sort of community risk factors rather than community resilience factors. And I think all of these things together contribute to our being a little bit stuck in terms of the field of disparities research. So that brings me to the second part of what I wanted to talk about today, and sort of the final comments that I have for you around stakeholder engagement. And so this is sort of a road looking at the horizon, and I chose this picture for a number of reasons. One is I think about what is the next frontier in health equity research in cancer as well as other chronic disease areas. And when I think about sort of a two-way street here, though all of those things to me speak to community engagement, I think there is a sea change right now within the field, moving us towards more integration and engagement of communities, patients, providers, and other stakeholders in the work that we do. It certainly characterizes some of the work that I've done in the past, and it certainly characterizes a lot of the work that I'm doing presently. But this idea of a two-way street is important, in that in communications theory and other places, there's this idea of it's not enough to push information out and expect that to result into translation of the work that we do into changes in practice and policy. There also has to be a pull. So in other words, policymakers, health systems, providers, patients, community groups need to be in a position to receive that information, and the information that we have needs to be aligned with their needs and interests in order for that partnership to be mutually beneficial and productive. And so what we've seen over the last, I would say, 10 years is, again, is really a sea change in the landscape of community partners and what it means to be a community partner in research. In the early days, we talked a lot about engagement of communities in just specific projects related to community-based participatory research in other areas. And those were all incredibly helpful for helping us to understand sort of these contexts in which disparities emerge. But I think increasingly we're moving towards this idea of, what can we do in terms of the research infrastructure for disparities that can really launch us into the next frontier with respect to health equity research. And so we're seeing a number of things. Of course, PCORI made huge changes, not only within how they do grants, but also in how others think about grant making with respect to community engagement and community impact. We also have a number of patient groups, which has been fascinating to watch, who are not only engaged in making sure that the research is about them, but it also includes them. To quote Carolyn Clancy, but it also is about how do we train up patient partners, community organizations to be effective leaders, to be effective partners in research. And it is really a different concept than I think sort of research partners or them as advisors and as subjects of the research, to more not only their subjects, not only are they advisors, but they're partners. Right, that idea of partnership is relatively new. And so this really sort of comes from the CBPR concept, but really, again, brought from the idea of an individual project into an overall infrastructure, right, where we're looking at things like, is it mutually beneficial? How is it likely to be long-term? What can we set up to make these things long-term? And the realization that these things are iterative and a learning process. We don't expect one project to solve our problems. It hasn't happened. It is not likely to happen going forward. And so to really make sure that the work that we do in health equity, in terms of the science, has an impact in terms of health equity, we really need to be thinking about these three circles. To what extent are we aligned with communities such that what we do is mutually beneficial? How can we ensure that we're building long-term relationships as opposed to project-to-project relationships? And then finally, how can we create an infrastructure that allows for and is facile in allowing us to do this sort of ongoing learning, this iterative process of learning between scientists and community leaders and other stakeholders within the organizations that we work. And so from my personal sort of journey here, really the work that I'm doing currently with the Aging Initiative is probably most aligned with these ideas, in that we have an infrastructure grant to not conduct a single research project, but rather to support patient-centered research among older adults with chronic conditions such as cancer, and really think about what does the infrastructure look like that enables us to do more engagement of patients, caregivers, and communities into the science, into the scientific inquiry. And so some advances that I think we've made, advantages, I would say, of community engagement to us as scientists, as well as to the broader community, are first of all, the increased the impact of the research that we do. When we better align the priorities of the community, we're more likely to have them pull in the research that we do, which means that the stakeholders, whether they be community leaders or health systems or policymakers, are more likely to see the research as valuable if it addresses specific and real questions that they're faced on a day-to-day basis. Another is this idea of enhancing the research quality. I recently did a cluster randomized controlled trial where we actually found that engaging patients and caregivers was vital across a number of different spectrums of that particular work, including recruitment. We had enormously high recruitment rates, retention rates of our patients. We also, this idea of how we conducted the intervention, but what our focus was of that intervention was largely driven by patient and caregiver and stakeholder engagement. And then finally, also the dissemination, our ability to translate that evidence into practice really made a difference, being connected to patient support groups and others who were actively engaged in wanting to receive that information and then talk with their community partners and their stakeholder partners about what it made to make things different and to change how the things were working for them in ways that really sort of spoke to their desires and their preferences for outcomes. There's also issues related to the expanding of a generalizability of research in terms of who we actually are able to get into the research. If we have people recruiting who are actually from the communities, we're more likely to engage communities that have heretofore been hard to reach. And finally, to reduce inefficiencies in research, rather than reinventing the wheel for each particular project, creating an infrastructure that really enables all researchers who want to take advantage of community engagement as a resource for their work to be able to do so. And so I've been talking with a number of folks at the SCI, and I think some of the core strengths that really excite me of the work that you're doing relate to things like scientific engagement across the continuum. The fact that you have excellent scientists doing work from bench all the way through to translation really heightens the potential for the impact at the community level. Also, the fact that you have strong leadership commitment and this NCI designation as a comprehensive care center really highlight the focus and the potential for community engagement to influence care and policy and practice and science. Further, leveraging your existing partnerships within and outside of Stanford and the networks that you have has been really inspirational to hear about the projects that you're doing and the high impact CBPR work that you're doing within your catchment areas to really focus on those priorities of the communities, as well as the dedicated community advisory board, are all aspects that I think are really innovative and really have the potential to move things forward. Some of the other things I won't be going into a lot of detail about now, but in terms of on the horizon, sort of where are we going, I think we can expect to see more communities in the driver's seat. I think we're going to see expanding strategies for long-term relationship building that include things like providing funds directly to communities to allow them to do mini grants, to do small tests of change within their communities, as well as providing training and technical assistance from academic medical centers, for example, to communities. I think we're going to see further professionalization, or already seeing that, of our CABs, of our community advisory boards, with respect to not only financial compensation, but training opportunities and leadership opportunities for those individuals and communities. I think there are also opportunities for science in terms of pipeline development. This is a great opportunity to identify promising students from affected communities as potential future scientists, as well as giving medical residents and other interdisciplinary fellows an opportunity to understand the needs of patients and communities from the perspective of science, and then to carry that into clinical practice. I think we also have chances here for career advancement for senior scientists who are interested interested at this point in their career in doing something different, engaging them in community engagement and sort of pushing us to the next level, as well as our ability to influence and impact the work, including generalizability and expansion of clinical services into previously underserved communities. And so I think I'm currently sort of a candidate for this associate director position, and some of these areas I think translate into sort of this first 90 days, right? I think there's a lot of work that has to be done. Anyone sort of working in this area, joining into group, doing this exciting work, there's a lot of listening and there's a lot of accelerated learning that has to happen. Another stage is sort of this prioritization and evaluation with those partners, and then finally co-design and optimization of future strategies and what could be possible with respect to community engagement. This is certainly what we've been doing within the Aging Initiative, and I'm excited about the possibility of doing that in partnership with the Stanford Cancer Institute. So with that, I think I'm out of time. So I want to say thank you so much for your attention today. Hopefully some of the things that I've said have intrigued you about the work that we're doing. And these are just a couple of additional sort of areas where you can find more about some of the work that we're currently doing in this area. Thank you very much.
Thank you so much, Alyce, for that really wonderful talk and incredibly informative. Obviously, it's a very, very large topic, and I'm sure that we have a lot of questions. I have some questions, and I neglected to say before you talk that the questions will be through this Q&A forum. So we have one question so far, but please, anyone in the audience who would like to type a question, if you could please just type it into there's a Q&A box at the bottom of your screen. Please enter that question now. We have one so far, and it's from Emily Greenwald, who is a graduate student in genetics. And she says, thank you so much for the great talk. I love what you said about viewing communities and people we study as partners in the work. I really struggle to convince other researchers to view patients as partners in the work. What advice do you have to persuade researchers who just feel like it sounds like a lot of extra work?
I think that's a great comment. And the fact is there are barriers, right, to community engagement, in particular when you think about how we're funded. So those of us who are on soft money, you're constantly running to the next grant, you're constantly thinking about the next project, and to add this community engagement component can seem overwhelming at times. And so I would say there are a number of different things. One is I think the environment that we had 20 years ago isn't the environment we have today. We have a number of different patient and caregiver-led groups who are now experts in being advisors and being good partners to researchers. I'm thinking about things like the PCORI ambassadors who are now all over the country, and you find them at research meetings all the time. They do an amazing job of helping researchers who maybe haven't done this before, helping them to get over that initial hurdle and helping them to understand what are specific strategies that they can use in order to be able to engage in this work without it becoming a detriment to their work, but actually an asset. Another is, PFCC Partners, which has been a partner of mine, where they're actually training, again, patients and caregivers to be effective partners in science. And so it's going beyond advocacy, which I think was one of the barriers previously. As scientists, we don't like to see ourselves necessarily as advocates per se, but I think patients and caregivers are now beginning to appreciate what science brings to the table, what randomization brings to the table. And because they're increasingly training themselves up to do this, they're becoming more effective partners. I would also say that one of the ways that I overcome some of these barriers is simply inviting some of these individuals to a meeting. It never ceases to amaze me how much people walk away and saying, wow, I had no idea how sophisticated these patient and caregiver partners are and their ability to really meet me where I am, right? I don't have to do all of the work. It really is people coming together, and it has to be mutually beneficial, right? And so I think all of those things have been very effective strategies. And lastly, I think in particular, as scientists, I think we all feel a commitment to bring along the next generation of researchers. And so I find that students, fellows, and residents are often very eager and very interested in this work. And they often then become the glue between investigators who may already be heavily engaged in community engagement work and those who maybe haven't tried it before and been afraid to dip their toe in the water. Being able to co-mentor early stage scientists who are very interested in this work is a great way actually to bring people in who may previously have been reluctant to do so, but they can see it and they learn it through the eyes of their students, through the eyes of their fellows. And it really does sort of bring about sort of a change in how people see this. It's less a burden and really more of an asset to their work.
Thank you.
Mhm.
We have another question. I'll ask a question that I had. I was very intrigued. I think it was when you were talking about your work on Medicare Part D, and there was that maybe surprising result, at least to me, the way you presented it, that there were increased disparities in diabetes, but in cancer there wasn't.
Mhm.
And then you talked about how that may be because there's you know, the treatment around cancer is very intensive and multidisciplinary, et cetera. And a couple of things I thought about that. One is there any role for comprehensive cancer centers in minimizing that disparity?
Mhm.
And is there reason for optimism, at least with regard to disparities in cancer based on those findings? Because clearly there are other disparities in cancer besides that lack of disparity that you revealed there. So is there reason for optimism, and is there work that we can do in comprehensive cancer centers?
Oh gosh, so much. It's a great question. And I think part of it is this gap that I talked about in terms of knowledge of patients and caregivers about what their benefits are.
Mm-hmm.
Right? I mean, I have a PhD. I've been studying benefits for years, and I have trouble reading
Mm-hmm.
benefits and understanding
Sure.
exactly what that means for me, right? And you can imagine a patient who's newly diagnosed with cancer, my goodness, right? And so that's why we have patient navigators and others to help with some of those issues, and certainly financial assistance with our advisors from the health system side. But also I think comprehensive care centers, that's where people go. So I can give an example from my own life. My father is currently undergoing prostate cancer. He's now having to take a second medication. It's incredibly expensive. The first thing I did was send him to the local comprehensive cancer center, right? Because they do have information for communities about these medications. What does it mean, this new drug? Is it really all that, is it really sort of worth it in terms of the cost it is to me? And where are the connections? Where do I need to go in the community, find the resources that I need to be able to help me with these costs, right? So that's at a minimum, that's one area. I think another thing that we need to sort of think about too is, yes, policy can seem to have an effect, particularly in cancer, which is fantastic, but the disparities are still there, right? We still see, we've done this work with cancer survivorship a lot, where we look at disparities in adherence and disparities in survival. So it's not that it eliminates all of the disparities. It's just that with specific sort of discrete tasks, if you will, around medication use, medication uptake, it seems to be more effective policy as an intervention, as a lever for moving things. But ongoing adherence, as well as ongoing concerns related to cancer control, but also other chronic conditions and disability, all of those things still require thinking about how do we do these things more effectively. And that's where I think comprehensive cancer centers have a lot to contribute in terms of clinical decision-making on the behalf of not only clinicians, but others within the healthcare system and patients about not only the short term, not only what happens with my cancer treatment today, but what does this mean for my cancer treatment or for consequences of my cancer treatment or for the other chronic conditions that I have 5-10 years from now, if I'm lucky enough to survive the cancer, right? And so helping patients think through that this is a process, that this is not a one-shot deal, and that disparities, quite frankly, will differ across those different areas. What causes disparities in treatment, for example, of chemotherapy and dosing, isn't going to be the same thing necessarily that affects whether or not someone's able to get adequate care for chemo-induced neuropathy, for example, 5 years post-cancer diagnosis. Those are two different things. And so understanding that we have to understand those complexities and what is the role of the cancer center and the research that we do to inform disparities and to inform care delivery and interventions across the continuum. Understanding which lever to pull when is something that I'm really excited about, right? Sort of thinking about, you know, when do you need simulation? When do you need machine learning? When do you need all of these other tools, bells and whistles and designs that can really help us to, again, sort of push things out to the next frontier in terms of disparities reduction?
Great, thank you. We have another question from Rachel Messia, who is on our COE team in the Cancer Institute. And she says, good morning. What are your thoughts on how we can diversify the expertise within the Stanford Cancer Institute to promote innovative research that will advance health equity?
That is a great question. And I've been faced with a lot of the same questions more recently in my current role as a director of faculty development here at Division of Research, in particular, thinking about diversity and inclusion. What does that really mean? Right, and we've also been doing this at the academy health level as well and thinking about our field. And so I think it means a number of different things. One is we all know we could do better with respect to the diversity of our scientists. Certainly the integration of community partners is important as sort of filling some of that gap. But some of this is we need more scientists who are thinking about these issues. And so how do we sort of create that environment that pulls those scientists in and allows them to be retained? And you've all probably seen the recent evidence from NIH and other places showing that underrepresented minority scientists are less likely to get that first R1 and more likely to drop out of science altogether when that first R1 gets rejected. And so figuring out how do we prepare scientists from a very early spot to really be resilient and be able to overcome some of those barriers. It has a lot to do with things like distant mentoring. So for example, the odds, I'll speak from my own experience, I did not have someone who looked like me or with my background as a mentor when I got my PhD. There was nobody. There was nobody to choose from, right? And that's true of a lot of underrepresented scientists. So I had to find other mentors in other places. And now I serve as a distant mentor for underrepresented minority investigators from all over the country. Actually, a couple are actually in other countries at this point. But really sort of figuring out how do we create the mentorship teams that are needed to be successful scientists when you have gaps. Right, and that goes for not just for diversity in terms of the racial and ethnic makeup or language of the scientists that we work with, but also the portfolios that they have in terms of their interest in community engagement and disparities and equity. And I think really thinking about the pipeline, I mentioned medical residents, that has been a fantastic opportunity for us to identify people who are interested but haven't necessarily done a lot of science before, to get them involved in science. And many of them go on then to get MPHs and then become leaders in the field. We're also working with historically Black colleges to try to understand how can we get even further down in the pipeline. I'm working with Stillman College, which is an undergraduate institution. They don't even have a medical school, right? But working with them to say they do have people who are interested in STEM. So I'm an advisory board with them, figuring out how do we help them understand the vast array of science that they can do and the different ways in which they can have an impact for their own communities, and really sort of addressing as well some of these geographic issues with respect to, the NIH money for a lot of these disparities work does not go to the communities actually experiencing the disparities. A lot of those R1s go to places I've been, right? They go to Stanford, they go to Kaiser Permanente or the UCs, they go to Harvard, they go to other places. They're not necessarily in the Deep South. They're not necessarily in Southeast, places in Chicago where we see a lot of disparities. And so really thinking too about what areas from the policy side need to change in order to make that happen. So any number of things, I don't want to go on too much, but I think there's a lot of things, a lot of exciting things, changes and things happening. And I think in particular now is the time. The challenges that we're currently facing provide a great opportunity to really address these issues.
And certainly there's a lot of interest in all of those subjects and a lot of conversation happening on campus and of course nationally.
Absolutely.
Next question is from Dr. Sri Seshadri, who is our VP of Cancer Services. And he says, thank you for a wonderful and thought-provoking talk. He wonders, on a macro scale, are there countries that have actively engaged their communities in cancer care? Are there other international examples?
Yes, so I can give you one international example. There are others as well. I think a lot of the challenges are similar across countries, but other countries in some cases have a different approach. So one example is Canada. So years ago, I actually evaluated for the Canadian government a project that was funded by their health department that basically provided a grant to a First Nations organization, which was included First Nations from across Canada, to actually get involved in community needs assessment through a massive survey, which had never been done before, of First Nations people around chronic disease prevention, around things like cancer, tobacco control, et cetera. And what was fascinating about that is it was very much the First Nations themselves saying, this is something we want to do. We can do this. We don't need you to do this for us. We want to do it for ourselves. And so they found the expertise that they needed among First Nations peoples who happen to be scientists in the various areas. They recruited from among the communities individual students and others, community members, they trained them to be research assistants, and to go out and be interviewers and to conduct the surveys and even to get involved in the analysis. And then they had biostatisticians who also First Nations people who took over the analysis piece. And again, it was what was phenomenal about this is that this had never been done before. right? And I think, and we've, in this, our country, we had the last survey in the scale that we had of Native Americans was done sometime around 1984, I believe, but that was the last time we did it. We haven't done it since. Right. And so what Canada did that I think is different and a more indicative to, again, Canada's not perfect with how they treat their First Nations peoples, but rather this was an effort to say, okay, we really need to think differently about what it means to involve communities. This is about self-determination. Right? This isn't just about we're going to provide care to you, we're going to tell you what you need to do. This is understanding that communities need to have some sense of self-determination. And certainly we've seen that in Native American communities here as well. I've done it with the Native American tribes, not exactly international, but it has that sense about it, in the sense that it's sort of the issues that come up legally and otherwise, and working with sovereign nations within the United States. We found the same thing, that when you put people in control of that community needs assessment, really engage them in meaningful ways in that process, you see outcomes that you can't really see when you sort of rely specifically, for example, on Indian Health Service. And there are other examples in New Zealand, excuse me, and other places where there's really sort of, a lot of it has to do with these Indigenous communities. But I truly believe that that work with Indigenous communities actually has import for other communities as well, other disparities communities within the United States. It's not a direct translation because, again, we're not talking about sovereignty, but this concept of self-determination, I don't think it has to be linked so closely to sovereignty. I think the concept of self-determination is important, and I think we see it over and over again when we have trouble with communities, when communities say to us, you know, you guys come in here, you do your trials and then you leave. You know, so you don't really care about us. Tuskegee experiment, those types of things. In sort of embed in communities a belief that researchers are not there to work with the community. But a number of people working in CDPR and other places have tried to sort of heal those wounds. But I think part of that process is really getting academic medical centers, getting comprehensive cancer centers even more engaged in partnering with communities to think about what does it mean for them to be self-determined? How can we support them in, again, being in the driver's seat in similar ways that we've seen in international settings?
So thank you. So this is, that's a good segue to what I think might be our last question, which is from Dr. Melissa Bondi. And she says, excellent talk, thank you. What we see disparities in survival are nearly eliminated when cancer patients are on trials. What are your thoughts on how we can communicate that to increase accrual to trials?
Absolutely. So again, we talked about, we see this across not just trials, but other things. When we get disparities communities engaged in treatment, engaged in health systems, they do better, they benefit, right? So it's not that these things that we have currently, these interventions aren't beneficial to them, but getting them engaged is a key barrier. And so some of the things that we've been doing to really address this issue is really getting better and more consistent about becoming long-term relationship partners. And some of the work that I'm doing with the patients group out at University of Maryland, I'm on their advisory board for accrual of older adults into trials, older and minority adults. Some of the things that we've been hearing from the community leaders are, I trust you if you keep coming back. Right? We can't expect to go into a community and say, I've got this great trial, no, it really works. People won't believe us. You know, it harkens me back to some of the work that Dr. Alsan did when she was at Stanford around the Tuskegee experiment. And the fact that the Tuskegee experiment is still associated with disparities in outcomes among African-American males to this day. Even though the study has been done for a very long time, in those communities where that memory is still there, it's still having an impact. And in particular, that impact is lack of engagement. If you don't trust us, you're not going to for care. And that is a long-term proposition. It's not a one-off. It's not a single trial. It's a long-term proposition. Engaging, again, creating infrastructures for ongoing conversations with communities, as well as other stakeholder and partners, having the clinicians at the table. Patients often trust their own clinician. They trust the judgment of clinicians. But having them both at the table together, it's amazing to me what the solutions you can come up with when they're all at the table together. We're not talking to them separately or assuming that we can't pull them together because the patients won't understand it, the doctors won't have the patients. I find that bringing all those communities together on an ongoing basis, you really have the opportunity to identify opportunities and then to leverage those opportunities into infrastructure chains that then have the potential to affect not only a single study, but multiple studies now and into the future.
Great. Well, thank you so much, Dr. Adams, for a wonderful, wonderful talk. And I appreciate your spending the morning with us. and being our inaugural speaker for Frontiers in Oncology. And thank you all the listeners and attendees. And thank you for all your questions. And just again, brief announcements. Jeff Shapiro will be scheduled shortly to speak in August. And we have the Carl Bluma lecture, Dr. Catherine Tierney, on August 11th. Thank you all very much for your participation. Thank you, Dr. Adams.
Thank you.
And we'll see you soon. Thank you.
Thanks. Take care.